Merck's Association case reports of 4 patients with vaginal replacement, and it's going to be presented by Dr. B.Demirogullari.
Congenital uterovaginal agenesis was described by Meyer, Rupinski, Küster, Hauser, and then described as MRK syndrome by Griffin et al. In 1971. MRK syndrome has 2 types. Type 1, known as also typical form, it has isolated uterovaginal aplasia and symmetric buds. And type 2, also known as atypical form, includes vaginal agenesis, asymmetric buds, renal dysplasia, circulatory somatic anomalies, and rare hearing defects. And this combination was described as Muse association by Duncan et al. In 1979. And MRK syndrome and American malformation have been reported in the literature. There are many cases, but Muse association and American malformation has been reported less. And first, it was reported by detail in 2001. One case, it was a postmortem study, and then the second case was reported from Turkey. This case was with vestibular fistula, and then last year, Wester et al. Was reported their case, 7 American malformation cases with vaginal agenesis and distal vaginal aplasia. One case was with Muse association. And the aim of this study is to pay attention to the combination of Muse association and American malformation and report cases from one center. The medical course of our American malformation patients were evaluated in terms of additional anomalies, surgical procedures, and follow-up. And you see the cases chronological arrangement, and 4 of 107 female cases had Muse association. Our first case was vestibular fistula. She had complete urinary aplasia, and the other cases were of colorectal cases, and the second case colorectal case had bilateral hemiuterus and patent fallopian tubes, and the third one had right hemiuterus and patent fallopian tube on the right side, and the last one had hemiuterus, low cervix, and patent fallopian tube on the left side. All cases had one functional kidney on the left side, and the colorectal cases had different degrees of vesicular reflux in different degrees, and they had different types of vertebral and spinal cord anomalies, and those 3 cases had extremity malformation. And in the first case, case 1, the diagnosis was established in the operating room, and she had a colostomy, and the vaginal replacement was able to done by sigmoid colon during PSAP procedure. And 10 years later, at her last control, she had full urinary control and vocal bowel movement with 1 or 2 soiling, and sometimes she complained, sometimes hemorrhagic discharge from the neovagina, but under general examination, under general anesthesia, we couldn't find any inflammation, and her kidney was normal. And in case 2, this case had a pouch colon. It was resected during the newborn period, and the sigmoid colon was used for vaginal replacement during the procedure, and she was followed for 1 year, and during this time she had frequent UTIs and pneumonia, and very recently we were able to close the colostomy, and I think she's a candidate for bowel management program, but there's no problem with a neovagina. Her kidney is heterogeneous and irregular. And case 3, was used for vaginal replacement during PSAR procedure because of the ostomy on the left side and the left colon. And she, after her 1 year control, she is totally incontinent, and she had frequent duties before bowel management program. Now she's under bowel management program, and she receives loperamide. The mother does neovaginal washes for mucus accumulation, and there is hyperactivity in upper whole of her left kidney. And this case was it's very confusing. She has this story, and when she admitted to our clinic, she was 14 years old, and there is a very long medical history and very many failed attemptions and many catastrophic complications. And you see on the left side what we found in the during the operation is anatomy, and we found a blind distal bowel during the operation, and we used this as a vagina, and you see the postoperative anatomy. And now she has permanent colostomy and ureterostomy and under hormonal suppression, and her kidney not good, and we are trying to follow up. She is living in very far away from our country. This association has classical urinary aplasia, venogenesis, and cervicothoracic spine anomalies. But this reminds a water association, but it's accepted that vaginal agenesis is not usual for water association. But with association and anatomic malformation, is it an overlapping of both association or a new entity? And how about art association, which is a male form of muse association? This male has Wolffian agenesis, and there is no data about art association and anatomic malformation. And what is their effect on the prognosis of these patients? We don't know yet. And conclusions, vaginal patency must be evaluated carefully in all girls with anatomic malformation, and if possible, it should be corrected during the procedure. And we check these patients because the potential risk of renal damage because of single kidney and possibility of neurovesical dysfunction resulted from spinal anomalies. And lastly, these cases must be operated in specific centers to prevent associated complications. Thank you.
Any questions? Yes.
For isolated form of MIK syndrome, but this case have colical malformation, and we have to correct the malformation, and during that time, I think it's a very good opportunity to correct vaginal replacement. And also, if we leave them with vaginal agenesis, they have heavy uterus and closed cervix, and I think they have a risk for retrograde menstruation and during puberty. That's why
Yes, Dr.
Obviously, you have many patients, you have a very good number of cases, and very many variated kind of pathology, and you work with very hard we try to stay away from the terminology, so from all the names, plurality, bad and factor, now morals, and then all these things, because Mother Nature doesn't follow those things. For instance, for us, in our terminology that we use, we presented a case of a colorectal collapse in the vagina, because when this was described, the acid in the vagina, they did not mention aneurysm malformation and that. So we prefer to be very descriptive in the cases that we present. The patient gets aneurysm malformation, there's urogenital sinus, there's absent vagina, with an atrophy on one side, one urine structure or not. That's because if we follow those terms, it will be very, very confusing. As more and more authors keep describing their own symbols and putting their own names, we don't like the phoneme. The Purarino was described as a heavy sacrum and annular malformation, as we say for that. But actually, it's not always a heavy sacrum. Sometimes it's the mass is in the middle and there's a light sacrum. But it's better to describe it like that, and the same with the Rokitansky. When Rokitansky wrote about that, he did not mention annular malformation. So we have to be more descriptive, and so we can understand each other better. And that's a suggestion.
Any other questions? If there are no questions, we're going to end this session, and I believe Professor